Hello, everyone, and welcome to this panel on medical specialists in the Journalism in the Time of Crisis conference. I am Sarah Everts. I'm the science chair here at Carleton University, and I am absolutely delighted by our panel today. We have Helen Branswell, senior writer at Stat News, Carly Weeks, Globe and Mail's health reporter, Brian Goldman, a radio host and podcaster for White Coat Black Arts and The Dose. And we may be joined by Vicatopia, CBC's health reporter, if he manages to find a moment amid the COVID fire hose of information to join the panel today. Just one little tiny bit of housekeeping before we get going. If you have any questions for the panelists, please feel free to add them in the Q&A box, which I will be able to see. But without further ado, welcome everyone. And I would love to start with a bit of a round robin, going through to each of the panelists to discuss, your perspectives and your experiences covering the COVID crisis. And I think I'd like to start with Helen, who was one of the first journalists, if not the first journalist, to raise the alarm about COVID-19 back in December 2019. So yeah, let's start with you. Any perspectives, any experiences over the last 10 months?
Oh, so many experiences over the last 10 months. It's been a very long year. I am fully convinced that 2020 is my least favorite year ever. I covered SARS back in 2003. I used to work for the Canadian Press and I was based in Toronto. And I was relatively recently a health reporter at that point. I was just about 3 years into it, which is not that long for somebody who had no background in health reporting. And I was really learning the ropes. And it was certainly the first time that I ever tried to report on a disease outbreak, let alone an emerging disease outbreak. It was fascinating. I really, learned so much, and it set me up well to be able to cover this one. But SARS-2 is not nearly as fascinating. Well, it is fascinating, but it's much more of a pain in the neck than SARS-1 was, and it's going to be with us for a lot longer.
Yeah. Thanks for that. Carly, how about you?
So it's been, as Helen said, and it's, first of all, an honor just to be here and to follow up on Helen's, after Helen is never easy. And, she's been doing so great. We're so proud of you here in Canada, just so you know.
Oh, thank you.
So I like to say to everyone, this is, one of the most challenging year, I think, for everybody in a lot of ways. But, the world of the health journalist is certainly been turned upside down, and it's been really, really a wild ride. So, very early on, I think my first byline about COVID-19, which we call the novel coronavirus, was, around the January 22nd mark, when we first were hearing that this is definitely transmitting between humans. And since then, it's just kind of obviously just gone haywire. And I think in a lot of ways, the health journalists who are following this closely were a couple of weeks ahead of where everyone else was. So we were sort of saying, we sense that this is going to be, a lot bigger, that there might be more, a lockdown is coming. And we kind of could see this happening before a lot of the politicians and elected officials really got on board. And I remember, we all can remember that sort of infamous day when the pandemic was finally declared, in the same day, the NBA canceled its season. Justin Trudeau's wife tested positive. And I think that was the same week at the Globe, the health team said, we're all heading home, pack up your things. And Andre Picard wrote his now infamous column, shut it down. And I think that ended up being one of the most highly read stories ever on the Globe and Mail website. And so basically from then on in, we all know how it went. We're all working from home now. And, from the health journalist perspective, me personally, I was pregnant at the time with this little lady who's now 2 months old, with a toddler at home. And so I was one of the many who was, juggling work and family life. And so that was difficult. We quickly retooled our resources and tried to figure out how to hit the ground running covering COVID. So we would have morning team meetings, which we had never done before. So every morning, and they still do, the health team meets virtually to discuss what's going on, what are the priorities, because one of the things that strikes me most is that we were in charge of writing the biggest story of our lifetimes without really knowing what was happening, and people like Helen, who've been writing about infectious disease for years, have the sort of advantage of kind of knowing a lot more than some of even though I'm a health reporter and I've been doing this for, 10, 15 years, I'm not as intimately, or I had not nearly the knowledge that I do now when it comes about some of the issues with COVID-19. And so, we didn't know early on, long-term care was going to be the story in Canada, how badly, we all knew there were problems in long-term care. We had no idea early on. And so we had to basically adjust and adapt as the story's unfolding, and you're trying to hold government's feet to fire, and you're not even sure what questions to be asking or what the issues are and what are we missing. So things that we did basically come late to the party to in some ways, the long-term care crisis. And then also the racialized disproportionate impact on racialized communities in areas like Toronto and Montreal that have been hit really hard. And that continues to unfold today. And what I see happening now with the second wave, unlike the first wave when, we're all in it together, everyone agreed we got to shut things down. Now no one wants to, or, half the population doesn't want to shut things down. And they're saying this is overblown. My hometown in Northern Ontario has had very few cases. And I see a lot of people on, social media saying this whole thing was, fake news and it's been blown out of proportion and we're not shutting things down again. And then you talk to people who have lost family members who are, going out to work every day and putting themselves at risk of this, horrible virus and getting very sick and dying. And there's such a disconnect there, and we're not reaching, and I think public health is not reaching and not delivering the messages that need to be delivered, quite frankly, that this is of how serious this threat is. And that, yes, most people will be fine, but there's a subset that won't, and they are being hit very hard once again. A couple of other thoughts. There's a lot of, fake news coming out, and I hate to use that word, but, we are seeing tons and tons of, I think we're going to talk a little bit about preprints and coming out and, all of this. This researcher has a new paper, that researcher has a new paper. What do you cover? How do you even decide right now? And there's so much disinformation being spread on social media. And I think that's, for me personally, one of the biggest threats right now is that people can choose their own adventure. You go on Facebook, you decide what you want to believe in based on the groups that you belong to and the friends that you have. And you can find a news story, whether it's a legitimate news story or not, that aligns with your beliefs now. And that is really scary. We've seen this for years with the anti-vaccination groups, and, the warnings from people about why anti-vaccination threats need to be taken seriously. And we're living that now. We're in big trouble because of the disinformation that's online, and we're not nearly as well prepared as we need to be to deal with it. And then I'll just end by saying I'm now observing the news that's coming out. And even with someone, even though I'm still kind of observing perhaps a little bit too closely now that I'm on maternity leave, I do find the messaging very unclear. Are you getting together with family at Thanksgiving? Well, you shouldn't be. But your kids can go to school with 30 other students, and you can go to a bar with your friends, and your kids can now go to dance class in Ontario. I live in Ontario, so that's the perspective I come from. Very mixed messaging, and no wonder the public is confused and doesn't know what to think.
Yeah, thanks, Carly. Hi, Vicadopia.
Hi there.
I'm really glad it worked out. We're doing a round robin, sharing everybody's perspectives and experiences. Since I'm speaking to you, let's go with you and then end with Brian. So Vic, how has the last 10 months been for you? Any sort of big picture experiences or perspectives you'd like to share for covering the pandemic?
It's I've been reporting on this almost exclusively since January 20th. And I've been a health reporter for 5 years now, although I've done health stories wherever I've worked in the country. And I didn't live in Toronto during the time of SARS. I was in Vancouver as a local reporter there. So I didn't really, it wasn't as huge an outbreak there. So I didn't really know what to expect. And I think I was maybe a bit optimistic that somehow it just would not reach Canada. And I remember one of our great colleagues, Kelly Crow, who since retired this summer, we have this wall in the office of different pictures of staff members in the health unit. And we wrote this quote down of hers on a sticky note and said, it was from February 5th. In 2 weeks, this will either be all over or all over us. And I think that was, man, was she right. She retired at a good time. So yeah, I was, like a lot of what Carly said, I honestly didn't know what to expect or know what questions to ask. I think what really struck me was the, when you look at countries like Taiwan or the UK and how they manage with their messages and their data gathering, it's our multi-level approach of the delivery of healthcare was a real impediment in so many ways here, whether it's the messaging, whether it's data collection or rules that are in place. I think that was a challenge where, like you have Dr. Teresa Tam, well-respected, saying it's safe to trick or treat. And then you have in Ontario, no, it's not safe in these cities. So I think it's just the challenge of the country we live in where, where our provinces and our healthcare systems, they have similarities, there are some real differences, there are different views and takes on things. So much of it is politicized if you look at Alberta and the approach they're taking, or the United States. So it's, when you're trying to tell a national story, that becomes a huge challenge, because what do you say? You can really only focus on, the provinces or places where it's most active. The disinformation and misinformation, it's infuriating. I mean, I've long covered that even before COVID-19, where, the sort of debunking stories, they're kind of easy to do, but it's just, people want to believe what they believe. I actually had a family friend email me or message me in WhatsApp about a list of things you can do, or foods you can eat and drinks you can have to prevent getting COVID-19. And his daughter was actually a chief surgeon in a hospital. And but that's just the way it is, like, it's just, people are just forwarding junk and garbage and random articles. And it's just like, it's stressful when you're trying to boil it down and try to get to the truth, reflect all parts of the country. The added challenge with broadcast is, you're trying to do all this in 2 minutes and make it interesting and visually interesting. The thing with doing health reporting in general for broadcast is there's kind of this oxymoron where you're trying to find a patient or a character that you use to tell your story. But when the thing you learn in covering science and health studies and research is that the experience of one patient is not going to be typical necessarily. So you're already kind of starting in this kind of dicey position where you want to tell a story based on one person, but you have to quickly contextualize it and put all those caveats in there and remind your audience that, this is what the science says, this is what the medical consensus is. So, that's an extra challenge, especially when something's online, like an online article, if you miss something, you can go back and look at it. You can't with broadcast for the most part. And so that it's just trying to get that clarity and depth and context and make it engaging all in one shot has been a real challenge with this, especially, this fear of all stories starting to look the same. That's another problem.
Yeah, no, absolutely. Brian, what about you?
So, Sarah, first of all, thanks. It's a pleasure to be on this illustrious panel, and speaking last, or at least in this round robin, gives me an opportunity to shout out Helen for the amazing work she's done since the very beginning. Like Helen, I was in Toronto during SARS, and I would agree with her that this current coronavirus, COVID-19, is nothing like what we saw with SARS, which was primarily an outbreak among healthcare professionals. Also, I want to shout out Carly, who's done some great work, Vic as well, and then countless other journalists, Kelly Grant, Jennifer Yang, Jennifer Pagliaro, without whom we would not have the context and dive into trying to figure out what's going on with the pandemic, and that's a reminder that with journalism under threat.
Yes.
With concentration of journalism and the economic case becoming more and more precarious, it's just so important that we have independent sources of information, notwithstanding all the difficulties we're having trying to report the truth when it comes to the coronavirus. As far as how our work has changed at White Coat Black Art, our show has always been about the patient experience and the culture of modern medicine. So we had lots of shows on racism in healthcare, sexism in healthcare, queue jumping, all kinds of topics and the heartbeat of White Coat Black Art is to tell stories. And last year, for instance, one story that comes to mind, we told the story about women with dense breasts finding out after the fact that dense breast tissue hides cancers, and so they would be diagnosed with cancer even though they had so-called clean mammograms, and that story helped to spur the provinces into notifying women when they have dense breast tissue and that they should talk to their doctors about how accurate a mammogram would be under those circumstances. Well, not surprisingly, the pandemic arrived and we completely pivoted to COVID-19, and I have no regrets about that. Although, it's amazing, how all the other healthcare stories have been completely pushed to the side because of COVID-19, and thinking about Teresa Boyle and that massive investigative piece that the Toronto Star did just a few weeks ago on chronic pain doctors and these block docs who do these expensive procedures that may or may not be of value. Certainly anecdotally, they think, patients think it's valuable, but they seem to consume a lot of healthcare dollars. And it's really important to keep doing those kinds of stories, and so hard to do those in the middle of a pandemic. But like everybody else, we made a tactical decision to pivot to COVID-19. And again, we focused on stories that are the heartbeat of our show. So for instance, we focused on seniors in long-term care who had no visitors for months, what was happening to them. And we focused on family members who wanted to be able to be at the bedside of loved ones in hospital and in long-term care, but couldn't. We did stories about people who come from disadvantaged communities, particularly people with disabilities, people who come from racialized neighborhoods and disadvantaged socioeconomically as well. In addition to that, we don't provide news you can use on White Coat Black Art. Fortunately for us, we developed a companion show called The Dose. And that show is designed to provide exactly the polar opposite. It's news you can use. It's meant to answer questions that listeners have, and they submit questions all the time. And again, we pivoted to the coronavirus. And this week we had a show on what to do during Halloween. And so the programs that we do are very, very practical when it comes to that. And again, I want to shout out the team of producers that I have the privilege of working with: Donna Dingwall, Jeff Good, Sujata Berry, our digital team, Ruby Buiza, and Brandy Weikley, our writer, our frequent writer, and Nicole Ireland, who is with CBC Health News and divides her time between that. And so between all that, we're trying to cover the landscape. I want to leave lots of time for questions, but some of the things that we've learned from nearly a year of pandemic reporting. Carly talked about a lot of them and set us up at the beginning. Numbers, I guess the first lesson I would say is that numbers don't lie, but they need context. So for instance, case counts are misleading, but the testing isn't targeted at, case numbers can be very misleading when the testing isn't targeted to populations at risk. The facts of the story change. We have to report the changes and condition our audiences to expect changes as we learn more about the coronavirus. I used to say, another point I want to say is that I used to say that health literacy was poor among Canadians. And then COVID came and it made me completely rethink of that. You know, we heard a presidential debate last night where former Vice President Biden referred to the reproduction number, and I thought, wow, you can just say that and people might actually understand what you're talking about.
But only now, Brian, only now. That would not have been true 10 months ago. Not at all.
Thanks to people like you, Helen, and thanks for telling me that. And then, you know, that we know, for instance, numbers can be misleading, but that hospital admissions and ICU admissions and deaths are
So I think, you know, health reporting went from a niche beat to the purview of general assignment reporters everywhere. And, you know, God forbid, as a, you know, recovering science journalist, I'd ever have to cover sports, right? But, you know, in terms of, you know, how the mainstream media has caught up to this beat, in your minds, what have been some notable missteps and some notable successes writ large that, you know, as you look back on 10 months of reporting?
I can jump in. I mean, I think it's a very difficult thing to take on initially, you know, reproductive numbers and incubation periods and things like that are not things that typically people would know about. And I think there's been, you know, a lot of people got on the learning curve and they're doing fairly well. One of my problems with this, and it sort of relates to something that Brian referenced earlier about not sort of messaging to people that things will change. This is a new virus and we don't know everything about it at the beginning and things will change. I remember this from SARS-1 and how, you know, something would change and you had to tell people this is not they didn't make a mistake before, they didn't know before, and now we know. And I thought, oh, you know, if this ever happens again, hopefully people will do it better. It hasn't been done better this time around, you know. Like when you look at, I don't know how closely everybody's following everything that's happening in the United States, but in the United States, the president is angry at Anthony Fauci, the head of the National Institute of Allergy and Infectious Diseases, because Dr. Fauci is telling him, you know, the public things the president doesn't want the public to be paying attention to. And so the president and his aides are constantly pointing to things that Tony Fauci said early in the outbreak as proof that, you know, he got it wrong, or they point to things that the WHO said early in the outbreak as proof that the WHO was in cahoots with China. In reality, you know, a tweet that the WHO sent out on the 14th of January, you can't hold that against anybody because it was, you know, there was so little known at that time. We don't do a very good job of explaining to people things will change, and, you know, we need to prepare people to understand change and put that change in context. As most reporters sort of are constantly looking for, why did that change? That change, because that must mean they were wrong before, or there's something nefarious here. And sometimes people got it wrong before, and, you know, maybe that it's appropriate to call them on it. But every time something changes in science, that's not a sign that somebody was hiding information before. And I think we really need to be careful about how we message that. And I think that, you know, some of the non-science reporters haven't caught up to that, frankly.
Yeah, thanks for that. Does anybody else have any thoughts on notable missteps or notable successes?
Yeah, I think what really struck me early on was a lot of this kind of breathless reporting about potential new treatments, and even the launch of clinical trials. We were seeing a lot of that in the news. I mean, I get that a lot of it was driven by U.S. news coverage. Hydroxychloroquine is one that stands out. I think what also drives it is the U.S. FDA has, I think, quite a different approach to authorizing treatments. Anything that might have a potential use for COVID-19 gets kind of an emergency authorization in the States. And in Canada, there's a much more conservative attitude towards it, where they are waiting for some stronger evidence of that. And I think what that causes. I mean, as journalists, we can't help but say, well, they've got this in the States, why don't we have this in Canada? And I think there's a lot of that reporting. I think we saw it with hydroxychloroquine. It also doesn't help that, as I said earlier, that there's a kind of politicization of research, where you have people like the Prime Minister, the UK Prime Minister Boris Johnson, announcing the results of a dexamethasone clinical trial where the evidence is not even, or the study itself and the numbers and the data aren't even released. And he's the guy that's announcing this. And I think I've seen some reporting where, again, this can't be helped, but not every clinical trial that gets launched needs news coverage. If people knew how, in the before times, how few clinical trials actually lead to treatments, I think that would be better sort of context for them. There's a hematologist in the US I follow on Twitter, Dr. Vinay Prasad, and he says, reporting on mouse studies is a bit like saying man buys lottery ticket. It's probably not going to result in much. And I have seen some coverage of that, including of vaccines. Clinical trials are complicated things. They're, a lot of the stuff, the faster a trial gets released, the higher the chance of error. If you want a trial, the results of some research released, make the group smaller. So the group of patients will be smaller, but your results will be less reliable. So, we have seen examples of that all over the place. I think on the positive side of things, I think journalists, physicians, and researchers have been demanding better data from the government, from all levels of government. I think this pandemic has exposed how poor a job we do of collecting this health data. And we're also learning why it's important. Carly alluded to it earlier about how disproportionately certain communities are affected. And, in the summer, we just didn't even have this information. And now, we're learning, for example, in Toronto, how disproportionately people are affected. For example, people who identify as white, they make up, about 45% of the population, but they're proportionally the least affected by COVID-19. The infection rates among Black Canadians in Toronto is the highest, and they're actually a small population. So, I mean, that is so critical, not only from a news perspective, but also from a public health policy perspective, if you're going to design, you're going to have more responsive testing. So I think and also there was another one that really stood out for me. We started reporting on excess deaths at CBC when we're starting to wonder whether, canceling all these surgeries was resulting in higher mortality, or whether there were higher rates of mortality that may not have been reported as COVID-19 related. So there's this kind of demand for this data, and the Public Health Agency of Canada kind of coordinated all this from the provinces because it's provincial jurisdiction. And it was there that we learned that Ontario has like a paper system of recording causes of death, and it would take months for them to release that information, which would be irrelevant at this point. And, it's faxing paper. That's how they do it in Ontario. So yeah, that really kind of opened a lot of eyes. And just getting back to the race and ethnicity, I think it's the reporting on the social determinants of health, which affects so much about people's outcomes. I mean, it's so relevant in this pandemic, those social determinants. And we're learning that people with all these conditions, high blood pressure or whatever, makes them more susceptible, or if they live in, close quarters, quality of housing. So, it really has changed the narrative about, everyone being susceptible. We know that there are just some people who, outside long-term care homes, that they just, they'll be fine, but others, the risk is very high. And I think the best reporting has really focused on that, because that's where people get the context, and I think it makes it more real for them too.
Thank you. Carly or Brian, any thoughts on that topic?
One thing I just wanted to say, I echo a lot of what was said in terms of things like missteps. I mean, I could talk for half an hour about the aerosolization, controversy, but I won't. I'll save my mentions on Twitter. But one thing I just wanted to say is that, all the missteps we didn't make as a result of the many experts who've made themselves available to us, like day or night, weekends, you name it. Like I send out a text message to a number of experts and I get an immediate response. I mean, that to me is one of the biggest changes. You know, it used to be you'd have to go through the communications person and you'll set up an interview for next week about this, you know, this study, or, you know, this person's not available. I mean, I think I speak for a lot of the health reporters, you know, we're on like first name basis with every infectious disease expert and epidemiologist. And we're able to contact this network of people and say, okay, is this what matters here? What's going on at your, you know, hospital? And they're coming to us with stories like they would never come to us before. You know, you fear for your job or things like that. You know, you don't want to just go off the official narrative, but the stakes are so high here that we're hearing from medical professionals in a way we never did before. And that has been the thing that has helped us elevate our reporting and know what the heck we're talking about, frankly.
Oh, thanks.
I concur.
Yeah, if I could just add, the only one downside to that is, I guess, and Carl, I don't know if Carly might agree with this, is that you sort of, even before this pandemic, you sort of cultivate a relationship with certain doctors, and now everybody is calling them, and you're like, hey, she's ours. Don't know why are you calling them? And I actually did see one general medicine physician on Twitter talk about how, you know, she was lined up for some interview, and it was just, they don't even, you know, there was poor follow-up. So, you know, like, it is so amazing how we have access to these physicians and experts, but it's just, you know, since everybody is covering the story now, you know, maybe sometimes they're not as handled with the kind of respect that you need for these people who are so valuable in this pandemic.
Interesting. Thanks. So I want to talk a little bit about vaccine hesitancy, because of course, you know, a lot of people see, you know, a putative COVID-19 vaccine as, you know, a panacea for returning us all back to normal. And yet, you know, vaccine hesitancy, even before the pandemic hit, was a huge issue worldwide and here in Canada, in the States. And, you know, now we also have a president down south who is politicizing a vaccine, you know, and it's raised fears that, you know, regulatory processes won't have full due diligence. And of course, you know, regulatory processes are different across the border, but the spread of anxiety knows no borders, and vaccine hesitancy knows no borders. You know, moving forward, you know, where do you see vaccine hesitancy having changed or not changed, or, you know, what's the impact of COVID-19 on that writ large? Carly, it looks like you want to say something.
I'm happy to jump in. This is my like sort of pet story. You know, I've been writing on vaccine hesitancy and anti-vaccine people for a long time. It's interesting, at the Globe, we actually don't refer to people as like vaccine hesitant anymore. You know, you kind of either are or you aren't. Like there's so much evolving in that space. And we knew before the pandemic struck that there's a sizable portion of the population that is concerned about vaccines. You know, I think in Canadian surveys show about 30% of people are concerned of like they have legitimate concerns or real concerns about the safety of vaccines, not just sort of theoretical ones. So they really do believe that there's something, you know, potentially going to harm them in vaccines. And I think that speaks to how powerful some of the campaigns have been to degrade trust. We have some anti-vaccine groups in Canada, but, you know, they're kind of everywhere. And, you know, with the internet, we have everybody, you know, you have your Del Bigtrees and the like who make the rounds and they do these tours. That's now been, like many other things, I think that's been amplified and sped up so much because of the pandemic. And so we're talking about the eventual COVID-19 vaccine. And at the same time, a lot of anti-vaccine groups and proponents who have their own agendas and things to sell and ideas to push, they're undermining, you know, trust in a vaccine that hasn't even been invented yet. And then the problem is you have a US president and others who are basically saying, we're going to push this vaccine through regardless of whether the safety trials are done. which then sort of adds this idea that maybe we all should be afraid of a vaccine because they're not doing the safety studies and they're going to push it through and they're going to, and we've had experts calling for vaccines to be authorized without the proper clinical safety studies being finished. And so you take it's sort of a perfect storm where you take, these anti-vaccine groups that are on the rise and they seem to be attracting more members. And then you have legitimate sources of information suggesting that we're just going to be injecting people, whether or not these things are safe or not. And I think that it's done real damage in the long term to this campaign to get people vaccinated, quite frankly. And I think that I originally thought back in March that this would be the moment that brings us all together, that we all believe in science again, that public health professionals are going to be the beacons of light that we look to. And in fact, the opposite is now seems to be true. Even in Canada, where we tend to sort of believe our authorities more, it seems like that sentiment is really on the rise. And I do fear for what will happen. I think that we're going to see yet more people turning away from things like vaccines, things that we know work. Just even looking at the people who sort of on my social networks who are, trusted people who are, have jobs and lives and families. They're not just conspiracy theorists who spend all day on the internet. They are posting things that are conspiracy theories that they found on the internet. So I think we're all unfortunately, we're all in a little bit of trouble here as a result.
I would like to jump in if you don't mind. I don't disagree with anything that you said. I think it's I in complete agreement with you. Although I do think there's a possibility that some of the factors that have made the ground fertile for vaccine hesitancy or rejection may shift with this pandemic. I mean, not in the immediate term, but if people, one of the things that's been happening is that vaccination campaigns, like kids aren't getting regular vaccines, adults aren't getting their booster shots for pneumococcal boosters or tetanus shots or whatever, we could actually see an increase over time in vaccine preventable diseases. And one of the problems with vaccines is when they work properly, people don't fear the thing that they're preventing, they fear the vaccine itself. If we actually see an increase in, measles outbreaks or, regular people actually contract tetanus. I mean, it's theoretically possible that there could be a greater understanding at some levels among some people that vaccines actually are very important. And in terms of COVID-19 vaccines, I mean, it's been here in the States, has been hugely frightening, frankly, to watch how the whole thing has been politicized, paradoxically, by a president who, before he took office, was a vaccine skeptic, who's now, who this summer sort of saw vaccines as his best shot at re-election. He seems to have come to the understanding that there won't be a vaccine before election day, that is out of reach. He's sort of turned his attention to monoclonal antibodies, the things he thinks cured him of COVID-19. But it is setting up a dangerous situation here. Yesterday, an advisory committee to the FDA met to talk about COVID vaccines in a general way. They didn't have data for specific vaccines. And it became quite clear that the FDA, which had been up until now talking about issuing emergency use authorizations, is actually getting nervous about the notion of using emergency use authorization. So it's a very difficult time here, and I don't think it's going to become less difficult as we get closer to vaccine. I would say, at least in the United States, there's so much transmission going on right now. This is going to be a very bad winter, and people's views about whether or not they want to get vaccinated may change as the number of people they know have actually become infected. Like Carly mentioned earlier, coming from a town that thinks it's a hoax because nobody's had COVID-19. As more and more people have COVID-19, that may change. And, as we all have to hunker down and stay indoors in the winter and pine even more for our the before times, as Vic mentioned. There may be some, especially if data show that some of these vaccines are actually fairly effective. You know, there may be some erosion of the anti-vaccine sentiment that exists right now, bringing the numbers back to sort of more of the typical, you know, yes, pro-vaccine, anti-vaccine kind of situation. I hope.
Thanks for that optimistic take. I hope
optimism.
you're right too. Vic or Brian, any thoughts?
Yeah, I've covered vaccine hesitancy, you know, even before this, and you know, I've even seen it in my personal life before. I was a health reporter, friends or neighbors who had this, and I think hesitancy is a really good word because it's people who are on the fence, and it's also so insidious in that all you need is a shred of doubt that you can plant in someone's head that kind of creates this hesitancy, and that's all it really takes. It could be. I remember prior to this, there was, you know, some secret study that affected how vaccines affected Black children that was making the rounds, and people are contacting me about it, and it's just those kind of doubts that are planted out there. And I think also what's contributing to this is, as I mentioned earlier, like we've never really had this much scrutiny or public or media scrutiny of drug trials and also these vaccine trials. You know, every time a person gets sick or there's a side effect, we report on that. And that adds to that doubt. And, you know, you need the context. That's normal. I mean, when you do clinical trials, there are always going to be these outliers that are going to have a reaction. So I think that is going to contribute or has contributed to the hesitancy, and also the amount of money at stake for these companies. I mean, these are companies that are putting these drugs through trials, and they really want to succeed. There is so much money at stake. Governments have committed to buying so many doses. So I think that really adds to some of the anxiety around the safety of it. And it's, I think that's really a hard thing to combat when you're kind of like, you know, you're suddenly aware of how sausages are made, and you know, like it's your feelings have changed on them. So that's kind of what it is. And I think you know, it's a product of the times we live in and the amount of coverage we're giving this sort of stuff.
That's interesting, Vic. Brian, it looks like you have some thoughts on this too.
Yeah, can you hear me?
Yes, absolutely, and loud and clear.
One story that pops up every once in a while, but we haven't heard enough about it, and I wish we did hear more about it, is the manipulation of public opinion through bot farms in Russia and elsewhere. There have been studies that have demonstrated, particularly with the measles, mumps, rubella vaccine, and I think there's been at least one study that's looked at bot farms that are sending messages to on social media, targeting people who are hesitant, reinforcing erroneous beliefs about the safety and efficacy of vaccines. And you know, I think we need to know more about how public opinion is being manipulated in that way. And you know, certainly I've done, when I was doing columns as the house doctor for CBC Radio, I did at least one column on that in the last year. But I think we need to take a closer look at that. You know, it's been said many times that public health officials have to do a better job of selling vaccines, but you know, I don't think they do a particularly good job. They tend to be overly earnest in their messaging, talking down, a bit condescending when it comes to vaccines, treating people like fools who are simply asking questions about the efficacy and safety of vaccines. And that's a story that I think we need to pay more attention to as well.
Yeah. Totally agree. There's a question, sort of a follow-up question about vaccine hesitancy from some of our participants. And, you know, just about vaccine hesitancy, should we then not talk or cover the risks of a rushed vaccine? I'm guessing the answer is no. But, you know, how do you handle that delicate, where's the sweet spot, I guess, is the question.
Brian looks like he wants to go. Go.
Yeah. Yeah. Thanks, Helen. The one thing I would say in response to that is that, those of us who are old enough to remember swine flu vaccine and other vaccines know that there's going to be a time when we go from a small population who's been exposed to a vaccine, a candidate vaccine that gets approved, to a much larger percentage of the population. We're talking about a novel infection to which nobody is immune, unless they've gotten the infection, and then we don't know how long they remain immune after that. And so I would be surprised if we don't see untoward side effects. And I think we need to be prepared for that. With swine flu vaccine, that was the first time we ever heard about Guillain-Barré syndrome. And I'm not saying that's going to happen with the coronavirus vaccine, but it would be irresponsible of us to not be on top of that, the potential for untoward side effects, because I think it's there, especially with the rushed pace of the vaccine development. It has been said that the fastest vaccine in human history was measles, and it was a 4-year effort. It took 4 years, and we're not spending 4 years on this. People are going to be rolling up their sleeves sometime in the first or second quarter of 2021. So we may very well see untoward side effects.
Yeah, I think, we have covered some of the pauses that have been placed on some of the phase 3 trials, and you can't not cover that. I think you really need to. You're doing the public a service trying to figure out how safe these things are. But I think you need to put them in context. I mean, one of the things that I find reassuring actually is that these trials are being paused when they see something wrong. I mean, this is the system working the way it ought to. And that is something that we need to point out. It's not abnormal for there to be a pause. People die, a person who's in a trial could die, could have nothing to do with the trial, but you have to stop and figure out whether there's a causal relationship or if it's just complete bad luck. We have to be careful in the way we explain these things and make sure that we tell people that this is the way the system is meant to be working. But I don't think you can ignore them. And especially given, as Brian points out, if all works the way we hope it will work, multiple new vaccines using platforms made in ways that have never been used for licensed vaccines before are going to be rolling out, sometime in the next year or so. And this is going to be a real world experiment of, unprecedented proportions. And so, we have to report on this stuff, but you also have to put it in context.
I just want to say I agree completely with that comment. And when it comes to any vaccine, I think that we instill more public confidence the more we're transparent. And I think it's incumbent on companies and governments to be as transparent as possible, which so far it appears they are. I mean, we hope, because we are reporting on these pauses and things like that. That is vital. And, we can always debate, and we should always write about, that when there is debate about vaccines. I mean, I wrote a story a year or two ago about, controversy about when to deliver the Gardasil vaccine, and if it should be Gardasil or the other vaccine, should it be 2 doses or 3 doses, and maybe it's even 1 dose. And those are conversations that we need to have. How effective is the flu shot this year? And what we don't want to do is start amplifying voices that just raise controversy for controversy's sake, or conspiracy theories that have nothing to do with reality. And I think we're seeing a little bit of that about mask protests, anti-mask protests, where I've seen the same mistakes or some mistakes that were made with the anti-vaccine protests are being made again with the anti-maskers. Just saying anti-maskers take to the streets to fight what, restrictions on their freedom or things like that. I mean, you put that in a headline, you put a photo of their posters saying that masks are somehow, trampling all over their individual freedom. And then that just gives them free promotion. So I think it's that fine balance of not repeating the claims.
Thank you. Any other thoughts on this?
Yeah, I just had one thought, and I don't know if this is related, but I have heard this debate in other circles about public opinion polls about whether people should get vaccinated for COVID or feel comfortable getting vaccinated once there's a vaccine. And the debate is, does reporting those numbers actually affect the outcome? Mm-hmm. Do people who are on the fence, who have doubts, are they looking to be validated for their doubts? And yeah, I mean, that's a question I throw out there. I'm not sure how useful polls are. I mean, they're useful maybe for governments because it'll tell them how much of a better job they need to do to reassure people that the process is safe. But at the same time, I do wonder what effect that has on individuals who are kind of on the fence or are looking for some sort of validation for their doubts.
Yeah, that's a hugely important question. I mean, probably one of those polls is one we did here at Carleton. And we found, for example, that vaccine hesitancy hadn't budged, even, in the face of a global pandemic 100 years in the making, or not in the making, but, that we hadn't seen. And, we also found that nearly half of Canadians believed 1 out of 4 pieces of misinformation. We really struggled, even is asking that question in a poll, right? So for example, one of the misinformation items people believed was, the bioweapon, that it was conceived in a bioweapon lab in China, or the debunked 5G network. But is asking that question in itself a problem? You do need to take a pulse of the situation, but, are you causing more harm than good? Anyway, that is a really great platform to kind of jump off to another question about misinformation writ large, which is, where's the sweet spot between trying to debunk misinformation that's popping up as a health reporter versus actually just trying to cover the fire hose of information? I mean, you want to address the misinformation, but there's so much other real important news that needs to be done. What's the sweet spot? How do you decide? And then also, how can you proactively fight misinformation? It feels like we are using therapies against misinformation, like fact-check articles, this is wrong, this is wrong. What's the vaccine against misinformation that journalism can do? So anyway, those 2 thoughts. Anybody want to jump in?
I don't know the answer to your last question in terms of, what is the how do we inoculate the public against that? I will say that, one of the pieces I wrote, I think in the summer, was about the fact that, we were starting to see sort of phase 1, phase 2 data from the clinical trials of the vaccines. And something that was becoming fairly clear was that most of these vaccines, in fact, all of the ones we've seen so far are pretty reactogenic. You get a real kick when you get one of these vaccines. You're likely going to know. It's not, most of us, you get a flu shot, you don't really feel something unless the person who administered it, hit the wrong part of your muscle or something. This is going to be more like the shingles vaccine, I think, which is really, you were vaccinated, you might feel crummy. So I wrote a piece sort of saying, look, this is going to happen. Thinking you can inoculate people against what will certainly come later on social media by telling people you should expect this. When people don't expect that kind of thing, that really gives, I think, ammunition to the people who want to make hay out of the vaccines. But that doesn't work in every circumstance, and I don't have the total answer. In terms of your question about the first part of your question was about how much time do you spend trying to debunk stuff versus doing your own reporting. That's something I think I'd be surprised if we don't all struggle with all the time. It's, there's only so much time, there's so much happening, and you can be working on something and then something comes up and it's like, okay, do I put this aside and go tell people how crazy this is, or do I continue to do what I'm doing? I'm not a huge fan of trying to debunk. I mean, let me rephrase that. That sounds bad. I don't want to spend so much of my time, trying to debunk theories, mistaken ideas or whatever, that I give up the opportunity to do original reporting. I really struggle with it.
Yeah.
Yeah, before the pandemic, we do occasionally do one of those debunk stories, and they're kind of slam dunk stories that you wonder, will they even make a difference? I mean, these sort of vitamin infusions, do they do anything? And well, here's what the evidence says. No. And then the story's done. Is it going to make a difference? I don't know. I mean, it's still out there. It's still a popular therapy. I guess the most successful misinformation is based on a kernel of truth. And, for this pandemic, I mean, there's so much stuff out there, but I think it's the ones that you see that are recurring that you have to pay attention to. And for example, the phrase boosting your immune system, like that's been around forever. And it's, there are careers and businesses based around that concept of boosting your immune system. And like that's again, that I've seen, businesses and, alternative health practitioners use this pandemic to, to generate some business and sell the idea of boosting your immune system. And I think that is an opportunity to actually do that story. Like, let's talk about your immune system and how it works, and the fact that you can't really boost it in the way you think you can. I remember I tweeted something about I think it was a chiropractor or someone who was, or a naturopath who was trying to encourage, people to get their kids' immune systems boosted with some vitamin C and vitamin D infusions. And I just posted, really? And someone replied to my tweet and gave me all these links to articles. And it's like, oh, okay, so that's the age we live in, where you just seek out the evidence. It doesn't matter what the journal is or the quality of the study. People just want the evidence. They seek out the evidence they want to validate their beliefs. And I think that's one of the hardest things about trying to debunk misinformation. You're not really going to reach everyone with your stories.
Good point. Ryan, do you have anything you want to add to that? Looks like.
Yeah, Sarah. Our approach at The Dose to doing stories that we've done before, for instance, the vaccine update, might be on the basis of whether there's new information. Whether it's been so long since we talked about what's new with vaccines for COVID, that it feels like it's time for an update. And I think we could use the same approach with debunking stories as well. We did a debunking story about where, about the theory, the discredited theory that COVID-19 came from a lab in China. And if there is a kind of an organic reason, if it's bubbling up again because of new information, then we might want to take another crack at it. But otherwise, I agree with Helen. I don't want to be doing that every week, but I think it's part of our mandate, it's part of our responsibility, because so many people are engaged in all aspects of COVID-19 that fire hose, as it's been referred to, that I think we need to try to put some light on some areas that haven't been well explained, and certainly we believe that just because we tell somebody, we tell an audience something once, doesn't mean that we don't have to retell them in 3 or 4 months. That's not.
Yeah.
Can I just add one more thing? I mean, this, as Brian was speaking, this example popped into my head. Recently there have been a few cases of reinfection that have come to light, and including reinfection where the second case was more severe than the first. And the internet was starting to go crazy. And Apoorva Mandavilli, who writes for the Times, is like a powerhouse in terms of her output. She wrote this great piece about, yes, there are 4 cases, but there's, only 4 confirmed cases out of, 40 million people who've been infected. Everybody calm down. And, you know, that's one way. If you're talking about how do we sort of get on top of this stuff, you can, that's not so much debunking, but that's seeing something that's about to happen, that's starting to, you know, a mushroom cloud that's beginning to form, so to speak, and getting in early and saying, hey, you know, yeah, this was to be expected. This will happen. The fact that we only have 4 cases on reference, so on the record right now, you know, is actually a fairly decent thing. That's one way of approaching things.
Good point. We have a question from Ivor Shapiro. He said, you know, in terms of, you know, we've been talking about selecting what stories to debunk, in terms of selecting people we speak to as science journalists or journalists covering COVID-19. He said, you know, in another session at this conference, one of the public health experts gently reprimanded a journalist on the same panel for excess reliance on, quote, infectious disease specialists, right? And I guess she had said, you know, why this is a public health issue. Why are you not talking to public health experts? And so, you know, in this, with this array of possible expertise to source, you know, virologists, public health experts, bioinformaticians, I can just, you know, the list goes on. What do the panelists think about this point of view of, you know, how do you know who to reach out to? And
Sarah, I have to jump in first because our episode of White Coat Black Art this weekend features not one, but 2 public health specialists. We have Tina Hinshaw, who's the Chief Medical Officer of Health for Alberta, and we have Eileen Davila, who is Toronto's Public Health Officer. I think one of the reasons why we don't necessarily talk to them is that they often don't deviate from their prepared scripts. And you'll have to decide for yourself, listen to the show. Did I manage to get them off their scripts? I'm not sure that I did. I have found personally that I'm more likely to get answers to questions when I speak to epidemiologists and when I speak to infectious disease specialists, which is why we rely on them. Those are our opinions at White Coat Black Art in the Dose.
Interesting point.
I'm going to jump in just because my baby might start crying. So this is a quiet moment. She's stirring. So we face this a lot. And again, it's actually kind of nice to take a step back for a while, but it's a constant debate. Who do you contact for this story? And for a while in the pandemic, you know, we were probably, and I certainly was contacting a lot of the same people, like not 2 people, but, you know, like a handful, 5 to 10 experts you might be speaking to on a regular basis. And I think that's important to continue doing because you have a relationship with these people and they can tell you things that are going on. Like, and I'm talking about people that are helping to inform the province, maybe behind the scenes, people who are, you know, in charge at the major hospitals in places like Toronto. But at the same time, you know, you do risk missing a lot of the important stuff that's going on outside of the big cities. First of all, that's often a problem that we have, you know, in large media outlets. You constantly are talking to people in the big cities. So what's going on in smaller centers and what are the expertise, you know, of other people that, you know, that are also seeing effects. You know, one story I wrote that, you know, I was quite proud of was about the impact that kidney patients were facing, you know, and I got sort of a tip from a kidney specialist in Ottawa about what was going on there. It's sort of like the double whammy because, you know, if you need to have dialysis, you're going into the hospitals all the time and your immune system is compromised and you're in the hospital all the time. And there were a lot of outbreaks in those units as a result. So it is a really important pressing issue that we face and one that we kind of can't let our guard down. You know, you have to constantly be reassessing who are you speaking to? Are there other voices? Are there people that are really good experts who you might have to nudge a little bit to get to talk to you, which, you know, to even make sure you're getting a representative sample of people. So I'll leave it there. But yeah, it's a great question.
Mm-hmm.
Vic, looks like you want to join in. You've got a pretty good zebra action on your face.
Yeah, I know. It's the sun decides to appear. I can't reach the blinds from here. I guess also for when you're in broadcast too, you do tend to gravitate towards people who can really, you know, give you great clips, who can summarize their thought in a really pithy way.
Yeah.
You're like, you know, you can't really, you give them 10 seconds and they can really nail it in 10 seconds. It's hard not to go back to those people. That's, again, you're kind of balancing the demands of broadcasting, which are sort of counter to sort of quality, the kind of reporting that you'd like to do, but you sort of have to fit it all into this sort of mold to make it work for TV. And there is this kind of bias towards people who are great talkers and great speakers and are really engaging in their interviews.
Part of the problem sometimes is that people who are great talkers and great speakers answer the phone when we call. Yes. Sometimes I don't know the circumstance of this public health person, but sometimes they have to get permission from the whatever, as Carly was mentioning earlier. If it takes a really long time, that's going to be a problem. Some people are not as comfortable doing interviews, even though they probably know way more information. It would be great to get at if they would do it. Conversely, some people are too comfortable giving interviews. I mean, we have to be careful in our business. I can't think of a polite name to call them right now, so I'm not going to use one, but there are certainly people who seek interview time a lot and are happy to speak about anything. And I, have made it sort of just a foundational rule of my reporting. Somebody who's willing to talk about any aspect of a story doesn't know enough about any of them to be a very good, person to speak to. I really take a great deal of, I respect a person who says to me, I'm really not up on that, or I am not the best person to speak to about that. What you really need to speak to somebody who is a biostatistician or an ecological biologist or whatever, and points you in the direction of other people, or even just in the direction of another class of experts. I think nobody can know everything, and the people who are good with a clip. I don't mean to snipe at TV reporting, because we all do it, but we all have to be careful about it, I think.
Looks like Brian wanted to jump in there.
Yeah, to the good list that Helen just gave us of criteria that we might use as a filter. I'm going to add one more, and that is, if I'm monitoring what experts are saying on social media, and if I get the sense that they're beginning to mount a campaign, where they're going after particular government officials and say that certain people should be fired, it makes me think twice about going to them for an unbiased point of view, because I think they're branching off away from expertise into advocacy, and when that happens, I think we lose credibility when we want them to be on our show just because they're good talkers. And we, of course, we have the same. We need good talkers in radio just as they do in television as well. But that's another criterion that we use. So I want to see what they have to say on social media as well. That's another criteria I use.
That's interesting. So we have a question that's kind of an existential question that I think we've all dealt with before, which is, how do you find the balance between reporting the specifics and simplifying the information for the public? But specifically for COVID-19, we are in a moment where, people on the street are talking about cytokine storms, like when, what? So yeah, do you have any thoughts on, where do you find that sweet spot when the public has a strangely well-developed sense of virology, and yet it doesn't, given all the misinformation we have?
Somebody told me recently that in March, everybody was a amateur epidemiologist, and now everybody's an amateur virologist. I kind of like that, but I mean, it's a teachable moment, if people can start to think about things in terms of, reproductive numbers and transmission dynamics and incubation periods and all that kind of stuff. Like, why should we deprive them of it? We should take advantage of that. I think it's great.
I think one thing for us in our reporting and discussions we had at the Globe, certainly, as the months wore on and, some of the appetite did wane, is we had to just reassess what our coverage looked like anyway. Are you reporting on the minutia every day, or are you sort of trying to figure out what are the big stories and how do we push this story forward? How do we tell this in a different way? And, as our officials started to actually release some data, it gave us something more to work with. Okay, so now the story is that more young people are being affected. So what does that look like? In those stories, you might have that opportunity to then get into some of the details and some of the infection rates and things like that, and what does this all mean, and our testing rates and positivity rates and things like that. Like, I agree 100% with Helen. Like, let's use this, and there's no need to dumb down the reporting, but I think at the same time, the other question we have to keep in focus is, how do we serve our audiences, and what stories are we trying to tell them? Like, every little itty bitty thing that comes out, or every sort of step forward, or some new journal article that comes out, that might not merit coverage, but we might need to take a bigger look at where is this pandemic heading in our neck of the woods, and how do we get on top of that? And we're seeing again, long-term care homes are again becoming a problem. So how do we tell that story in a new way? And I think that'll continue to be the challenge in the months ahead.
I think that what we, so 2 points, and I don't know how much of what I said in the beginning in my introductory remarks was muted out, but I think I have found that the health literacy of our audiences is much higher than it might be in a lot of other stories, a lot of other health stories, because there's so much that we don't have to explain, because there's an incremental increase in literacy to do with COVID-19. So that's one point I wanted to make. So aim high. The other thing that I want to say is that the data that we present is contextual. If it's important to the story, then I think we have to explain it. So for instance, if there's a story, as there was in the Toronto Star in the last couple of weeks, about how Melbourne, with a similar population to the Greater Toronto area, had a lockdown, and it was triggered by a certain level of infection, of community spread of the infection, compared, and where Toronto didn't have a lockdown, like a second lockdown, then you have to explain, well, what is it about the numbers? And then you have to start to talk about reproduction number and other statistics. So I think that you provide that data when it's necessary, and when it isn't, when it gets in the way of the story, then perhaps you don't provide it.
So I have another existential question. So both Helen and Brian touched upon it in their opening remarks. This issue of that there's been a lot of criticism about public health recommendations changing. And this criticism, often from the public, sometimes from journalists, is often framed as, science keeps changing and scientists keep changing their minds.
Thank God.
Exactly. And so, if you know anything about science or public health, you celebrate this change because it indicates, incremental evolution of our understanding, and you don't want public health officials to be digging their heels in. But I think, this criticism has revealed a fundamental public misunderstanding about how science operates. And I'm wondering, is this because health and science journalists have spent too much time doing the GRIS reporting on, single studies in the past? Or I guess more writ large, what role has journalists played in this public misunderstanding? What role do we play in changing it?
I don't have the answer to that, but I think a small point worth mentioning is whenever, for example, you're reporting on a study that points to X, sometimes you can actually go, there's sort of a consensus about certain things in science. And I think we could spend a bit more time reporting on that. And there are resources available for that, like the Cochrane Review, for example. Where they will, and they're quite responsive, where, for example, they're looking at convalescent plasma, and they will look at the scientific landscape at that moment and say, these are all the studies, only these certain studies are of this higher quality, and this is what we can safely conclude or not conclude from this research. And I think using that sort of background context really, I think it sort of helps the audience with when you're reporting on new science that seems to be changing, because there's not a lot that really, there's not a lot of new findings that happen in a vacuum. They're iterative and they build on other findings. And I think giving that background to people sort of helps that, helps the understanding.
Early in my career as a health reporter, I covered a lot of single studies. It, was kind of...
It's the bread and butter.
That's exactly what was coming out of my mouth. The longer I've been at it, the less I do of that. But I have to confess, I'm in a job right now where my bosses don't want me to do, single studies. They want me to do, sort of bigger pieces. And that's a huge luxury. Not every journalist has that luxury. So I don't know that I have an answer for everybody, but it is, as Vic points out, a single study is a single study, and it may add something, it may raise, it may challenge, but it's not going to answer the question.
Sorry for that feedback there. I'm sure she does agree with you, Helen, but
we're in complete accord.
But no, I completely agree. I remember it was always what's the study today? What's the study? We used to write a lot on studies, and now, and again, I'm in we're in the fortunate position. I work at a big national newspaper with multiple health reporters, and so we can kind of write some of the bigger stories. And I think about some of the places I used to work and some of the, where I came from, and they have a skeleton staff now. And I think part of the issue, this broader issue facing journalism is there's simply not enough of us to do the job, and so I think it's very difficult, even at a large paper like the Globe and Mail. When we get on something, you can easily start to educate and inform the public. We all see how much the public does understand about the nuances of COVID-19. So we can sort of, help shape thinking and, things like that and inform. But it's very difficult because, even we have to really be, we have to pick and choose because there's not enough of us to report on it. And then if you are, reading your local paper, and a lot of people only rely on their local paper, or their local source of news, you're not necessarily hearing any of this. And so you hear snippets of a conversation, and that's when, the Facebooks, everyone scrolls social media. So you get up in the morning, you're scrolling through your phone, and you see someone posting something that they saw that's clickable and shareable. And then that becomes something that you think, even if it's a, conspiracy theory that is completely wrong. And I will say that, public health officials do a great job at what they do, of helping keep us safe and, making sure hopefully, enough vaccines in stock and that kind of thing. But we don't spend nearly enough time on, my opinion is that on the public health messaging, and they're not on, a lot of the public health offices aren't on Instagram or TikTok, where a lot of eyeballs are. And so their messaging is still sort of in the, in the 20th century. And so unfortunately, they're up against people that are really, really good experts at social media and getting posts that are likable and shareable. And again, just sort of on that point of, degrading the information sources that are out there and contributing to this flow of misinformation.
Thanks. Brian, it looks like you also have a thought on this.
Yeah, Sarah, you framed the question as an existential question, and when you put it that way, I feel compelled to remind everyone that about the politicization of health information, and that, for instance, we've witnessed something absolutely unprecedented, at least in North American reporting, to have a president of the United States attacking Anthony Fauci for changing his mind on vaccines, on masks, and saying that somehow his information is unreliable. He's unreliable as an expert, and that is exactly what President Trump has suggested. if Trump is an aberration and everybody and there's a different president and kind of we go back to the way things were, then fine. But I don't think that's going to happen. I think what he's done is point the way to say, see, you can take on experts and say that they're politically motivated, that they voted, he's a Democrat, and once people get the idea that it's okay to do that, then who knows, maybe the floodgates will open. And if that happens, then it's going to be even more incumbent on health reporters to calmly, quietly explain what their methodology and that they're trying to be the most honest brokers in a world where there's incomplete knowledge that is being added to incrementally all the time. But it's a real challenge right now.
So I have a question from the audience. How important is it for health reporters to have some sort of medical education? How can you get up to speed quickly if you don't have it and you're forced on the COVID beat or the health beat writ large?
Brian, go ahead. The only doctor on the panel.
Right? I think that's worth pointing out that, some of the most esteemed journalists on this beat don't have a medical background, but Brian does. Brian, you want to start? You've just muted yourself though.
Well, now have I unmuted myself? Can you hear me? Good. So the first thing I want to say is that there have been lots of studies that have looked at the accuracy and the reliability of reporting, and basically, you need to be a health reporter who's on the beat. There's certainly value in specialty reporting as opposed to being a general assignment reporter. You don't have to have a medical degree or a nursing degree or a degree from another health profession. You just have to be dedicated to what you do. You have to use your skills. You have to be prepared to learn. You have to find experts that you can rely on. You have to read up on stuff. There of course are, at Ryerson and Carleton, there are medical, medicine and science reporting fellowships and master's degrees. And so I just want to disavow anybody who thinks that you need to have a medical degree to do this. In fact, it can be quite the opposite. That medical degree can be used for evil as well as for reliability in reporting.
How can it be used for evil?
Dr. Mercola, take a bow. Dr. Oz, take a bow.
Right.
Unfortunately, there are far too many examples of so-called physicians who use their platforms to misinform the public, and of course that's fodder for health reporters to try to debunk. That's been done by Vox and other esteemed media outlets as well.
I kind of cringe when I think of all the mistakes that I've made probably over the years, just because I don't have a medical background. And some of the stories, if I can only remember like a fraction of what I've actually written, but sometimes, you do sort of just shudder and think, why would I have ever written on that? And we have the luxury maybe of time, when the stakes weren't quite so high, you write a story and, you got all the facts right. You spelled everyone's name correctly, but, maybe it was a mouse study that never should have seen the light of day. Right. And things like that. And so I think that, I have a much, broader knowledge than I did many years ago. Still not where I need to be, still need to keep learning. And that's one of the joys of being a journalist, as you always are. But there are courses that you can take. There are, and I think the number of those that I've seen certainly have actually grown, which is great. And there is more of a move in some public health institutions to actually create some of those courses and things like that, which is great. And so we need more of that. At the same time, if you're a journalist and you're just kind of thrown into this and say you're the COVID reporter this week, I think one of the best things you can do is start following people like Helen, and people who sort of know what they're talking about, and follow closely what they're interested, what they're writing on, what are they saying, what are some of the top experts saying, and you can quickly sort of get at least a base of knowledge. You're not necessarily going to be able to write a scientific paper on it, but you'll start to have a really good at least base of knowledge, and you can avoid some of the big pitfalls, and it will really help guide you. But again, it would be it would be great if all of us, myself included, had more of a knowledge base. But certainly there are ways that you can catch up without having to go back to school for years and years.
Yeah.
I think doing this job, it is a learn as you go job, and I think it's there's almost an advantage to coming in without a medical background, in that you have to, the people you interview, you have to get them to explain to you things that you wouldn't necessarily understand because you don't come from a science background, and that actually helps you tell the story. There are also a couple of really great resources available. There's a U.S. association called the Association of Healthcare Journalists, and if you join that, you get this great little booklet. It's a PDF called Covering Medical Research, and it's a guide to reporting on studies, and it actually informs a lot of how you should approach reporting on health. And it's written by Gary Schweitzer, who does healthnewsreviews.org, and yeah, it's a good sort of base to begin from.
Helen, did you have a quick thought?
Journalists, in newsrooms, there's just this long tradition of moving around, going from beat to beat, learning how to, you start out as a generalist and you cover City Hall, or you might cover the provincial legislature. You don't know that much about what you're reporting on initially, and then you acquire a lot of knowledge. I did that for the first half of my career, and then I became the health reporter. The health beat learning curve was the steepest one I ever had to climb. It was, and still, yes, there's lots of stuff I don't know, and it's daunting, but at least I know now where to go when I don't know the answer to things, which is helpful. But for the first 3 or 4 years I did it, which is a long time in a beat. I went home almost every night thinking, oh my God, what am I going to find out that I wrote, that was wrong with my story? It takes learning. And so, would it have been nice to have had some science background? Yeah, it would have been, but I didn't. I have a BA in English literature.
Thank you. Yeah, certainly could help, but is absolutely not necessary. So in the last minute, I just want to do a quick round robin again, just to ask each of you to tell us your parting thoughts. What is the thing we should keep in mind as we face the second wave, or the extension of the first wave, as wherever you may be? Writ large, what should the media be covering? What are you thinking about? Just a quick thought from each of you. Let's start with you, Vic.
Okay, wow. There's a lot. I think I would like. I think what we've learned from the first wave of this is that what had happened in Europe really was a sort of glimpse into the future of what happened here in Canada. And I think we need to really pay attention to the way foreign governments that have similar healthcare systems to Canada, how they respond to the second wave and what works and what doesn't. I also think we need to, so that's sort of the macro view. The micro view is I think we need to really follow some of the communities and the places that are going to be hardest hit, and not sort of allow the numbers, just the raw numbers, to sort of influence how we tell the story, but actually dig a little deeper, whether it's the certain communities that are most affected, or the level of hospitalization that's taking place with this increase in numbers. So I think it's sort of paying attention to the bigger picture, and also not to ignore the things that are happening next door.
Good points. Brian, what's your parting thought?
My parting thought, Sarah, is that I'll be paying attention to the times when I'm getting too close to groupthink. That everybody in health reporting is starting to sing from the same song sheet and saying the same thing, and just checking myself for assumptions that we're making. So, or that we're talking to the same experts who are making prognostications about COVID-19, and then checking them to see, are they actually turning out the way they were predicting. So for instance, the second wave primarily involving younger people, and now we see There are concerns that as more people, younger people become infected, that inevitably that will result in older people getting infected and therefore more hospitalizations and more deaths. And so I'm going to keep reminding myself of that and ask, is that happening? Is that actually happening? Was that a genuine prediction that we needed to be concerned about? Or did it turn out to be false? I'm also going to be looking to see if lessons are being learned on the fly. For instance, how we manage people in long-term care who have COVID-19. We have some early indications that they're not learning the lessons, so that the infrastructure hasn't been changed fast enough. Those are the kinds of things I'm going to be watching over the next few months.
Thank you. Carly.
It's become increasingly clear that, we're not all in this together. There's certain people that are bearing the brunt of this, and others who are saying, let's just, it's business as usual. And we know a lot more than we did back in March and April. And so now, as journalists, we are in a position to push back on official lines and to say, why aren't you doing these things that we know work? We have experience with a wave of this already. And, I think also telling stories in a different way. We were very constrained early on, no access to hospitals. A doctor pointed out to me that people might take this more seriously if they saw people that were really sick with this. And we didn't see a lot of that here in Canada. My colleague Kelly Grant published a piece last week. She spent 5 days in a hospital. That kind of reporting is incredibly valuable, and it makes it real for people. We need more of that, and more of the storytelling of the people that are bearing the brunt. Make them real to people. If it's racialized communities in cities like Toronto that are facing such high rates of this virus, let's tell their stories, because it create empathy for these groups that are at risk and create the circumstances that can keep them safe.
Thank you. Helen.
Two things. Vaccines are going to be incredibly important in the next few months and then well into next year as we try to figure out how to live with this virus. Vaccines are incredibly difficult to design and test and deploy. There are going to be all sorts of issues. I'm surprised, frankly, that none of the candidates have fallen out yet. It's unusual, and statistically, it's a bit of an anomaly. So I think we need to be prepared, and the public needs to be prepared for the fact that, something might not work, or that there might be problems that come from use of some more of these vaccines. The other thing I would say is I've thought for a really long time that the public hasn't been well prepared for how long we're going to be living with this thing. This is not like a 3-month thing or a 1-year thing. This is a new virus that has completely seeded itself in the world. It's not going away. It's not like SARS-1. It's not going to sort of, we did not manage to extinguish it. It's here. We need to learn how to deal with it. Our immune systems need to learn how to deal with it. And so there are going to be, changes for years. This is, and I don't think people get that. I think this stuff about taking off the masks and pretending that this isn't real, I think it's because people it hasn't been explained to people very well that this is the new reality. We're not going to have to wear masks forever, but there isn't a quick way out of this, and people need to understand that. You agree, Brian?
Yeah, seeing a lot of nodding heads. Thank you, each and every one of you, for being on this panel today, for your thoughts, and for doing the work that you've done over the last nearly a year. Stay strong, and again, thank you very much.